We are meeting on the traditional lands, waters, and territories of the Anishinaabe Nation, the people of the Three Fires known as Ojibwe, Odawa, and Potawatomi nations, whose historical boundaries include Goderich in the south, the tip of the Bruce Peninsula in the north, and the Nottawasaga River in the east. We do this as part of our support for the Truth and Reconciliation Commission with the Chippewas of Saugeen First Nation and the Chippewas of Nawash Unceded First Nation, now known collectively as the Saugeen Ojibwe Nation. We also recognize the contributions of the Métis Nation of Ontario, whose history and people are well represented in Bruce and Grey counties.
So, ladies and gentlemen, my name's Jenny Amy, and I'm president of the Rotary Club of Southampton, and I'd like to take this opportunity to welcome you to our regular meeting this evening, which is completely irregular. Our membership and the over 185 people who signed up are here and quite interested to hear what Dr. Arra has to say to us. We want to welcome you, Dr. Arra, as our speaker this evening. Dr. Arra is the Medical Officer of Health for Grey Bruce. And I won't go into all the details about his bio that was made available to all of us earlier when we signed up. But I do want to thank you, Dr. Arra, and your staff for your open communication and your responsiveness over the last year and a bit. I know people in the tourism business, in the retail business, and many of us in other community groups like the University Women's Club and others have we feel like we know you. You've been there for us. So without further ado, I'd like to turn the meeting over to you, sir.
Thank you, ma'am. Thank you, everybody, for having me. It's an honor. Thank you for your remarks. We're glad to be of service, myself and my team. I'm just going to share my screen to the presentation, if that's all right with the group. And if you can just give me the thumb up, if you can see the presentation. Okay. I need to change something here, sorry. So, the presentation is disclosure. It's requirement by the Royal College of Physicians and Surgeons. It shows I have no interest, commercial or grants or other funding. I'm presenting in my capacity as the Medical Officer of Health for Grey Bruce Health Unit. The private sector does not even know I exist, and that's essential to appropriate function as a Medical Officer of Health. Overview of tonight, just touch base on a few things there. Better understanding of the specialty of public health and the local epidemiology in Grey and Bruce. Our overall goals in the response to the management of the emergency and the roles of the health unit. And finally, just a slide and a couple words about the new normality until this pandemic is over. And public health preventative medicine, it's a specialty of 5-year training, and usually there is some subspecialty in it, and that's after medicine. It's very similar to surgery in the length of time. And some of the subjects that we look at other than medicine or infectious disease, and the ones here bolded are related to the management of the emergency. There is emergency management. There is a component of it of the 5 years longitudinal, how to deal with emergency. People understand fire or police related emergency. And it's the same principles, same tools we use. Whenever it's related to infectious disease or environmental health, the Chief Medical Officer of Health will be leading this. It wouldn't be the Chief of Police or the fire. Nevertheless, it's similar function. Senior management, there is training of 2 years to be a CEO of an organization, how to manage teams. Communicable disease, also related to this emergency. Understanding the epidemiology is another layer of managing a pandemic. And what is considered a novel virus for all of us as citizens is considered bread and butter for public health. We are prepared actually for the management of novel viruses. That's a subject that we study And we, on annual basis, we work with organizations across Grey Bruce in our area to prepare pandemic plans for the flu, which are very similar to novel viruses. We manage outbreaks, as you know, in retirement homes, in the community, in workplace, and those are not different from COVID as a pandemic, as an outbreak. Sorry, just finding trouble moving the cursor. Here we go. Definition of emergency has different definitions. The essence of it is any situation where the resources locally will be overwhelmed or imminently to be overwhelmed. And there are complex emergencies, and there are certain criteria to call an event or emergency complex. Usually a couple of them would meet the criteria, but in COVID, all of these are met. It is cross-jurisdictional, it requires special knowledge, it poses significant risk to the first responders and to individuals, have potential cause of widespread damage and loss of life, require more complex structure and formalized plan, and it extends over a long period of time. So we have a pandemic that we're dealing with, the likes of which we haven't seen since 1918, 102 years ago. And that pandemic, the Spanish flu, claimed 50 million people worldwide. So as humanity, we're doing much better right now. And obviously we have tools of communication and others that are different. There are certain aspects of the pandemic management remains the same, and as if we didn't learn much during history, from history. One of it is turning the mask into a political statement and organized groups. And that happened in 1918, guaranteed. Second wave, it was there. The third wave, it was there. And it escalated to organized protest with, unfortunately, loss of death, loss of life for officials and officers. Some of the management tools that we use, and IMS, Incidents Management System, is the same tool that the fire and the police use. It was developed by the American Army and was used the first time in non-military operation in the 1977 wildfires in California. It was refined later by different groups, including our system in Canada after SARS. We added quite a useful addition to this tool. It starts with the command. The emergency has to have one source of direction and one source of communication. There are safety officers that would ensure our team are safe, liaison to connect with other partners, communication to send communication to the public, and all of these will happen through the command. On the ground, we have the planning, the logistics, and the finance. So the organization itself turned into this tool, and we have 110 employees usually. Now we had 150, so we beefed it up. And this cycle is the same cycle used for any emergency. You'd look at it, prevention, that's key. However, when it starts to be imminent, mitigation will take place, then preparedness and response and recovery. And we're in this stage, which is a lengthy response. Usually in fire or police, the bulk of this cycle would be for anything but the response. The response is really quick. Here, yes, we did prevention, and we do it every year. We prepare for things. We ensure many aspects are in place for the management of the emergency. In January and February 2020, I spoke with the Board of Health and the council for the two counties before the emergency was announced by 2-3 months. And I said, we need to dust off our pandemic plan. And that window of time of 2-3 months preparation really allowed us in Grey Bruce to achieve the success that we have managed to maintain. One concrete example, February 2nd, I was sitting in this office with the chief of ambulance for Grey, and he probably was not as quite convinced that EMS will be deployed to do many aspects that are outside of their scope. He was all in. I shouldn't say that in a way that, but you know, when you describe the caliber of the response, many people who are not trained in public health might not see it as so. Nevertheless, that preparation was quite useful. A very busy graph, just to walk you quickly. If you look at under this communication, is the the underlying principle for the success of an emergency. Too much communication is not enough, and it really entails all these different systems. IMS is the one I was referencing before. COOP is whatever relevant in the organization to address public health issues that are not COVID. There is still rabies, potential rabies vaccines, and potential meningitis and meningitis cases, and we deal with them. And HIRA is, again, that's part of the preparation early on to map out the risk and the magnitude of it, and training exercises take place. So it's a specialty that's wide and broad and deep. Emergency management in public health is a subspecialty, and this has always been an interest for me. I never really imagined in my career I'm going to be dealing with this type of emergency. Nevertheless, who trained me and the system that we train in is quite prepared for it. If you follow Dr. Bonnie Henry, she's actually a subspecialist in that, and obviously her province is quite successful in responding. She's the Chief Medical Officer of Health for BC. And you look at the local epidemiology. Currently, we have around 700 cases, 11 active cases, 2 deaths. Unfortunately, it happened in 2020. We managed to have 0 deaths. It's a pandemic, and if you look at the numbers across the province, you average it, we remain standing in a very good relative position. There is only currently one outbreak in long-term care, and it's 1 case. Everybody else is non-symptomatic, and all the measures are in place. I have high level of confidence this will end up similar to the other ones. No transmission to anybody else. So there is an iron ring around our most vulnerable in long-term care. Only the first long-term care outbreak happened before universal masking, that many residents had transmission. The efforts of the healthcare workers in that home was tremendous in a way that none of them needed hospitalization, let alone having severe complication. So the rest of the long-term care outbreaks, retirement outbreaks, had 0 transmission past the first case identified. And again, that's a collective effort from everybody in the community, not just the facility. This is a graph after the first wave, and each case transmitted to a number of cases. This is an outbreak in a workplace outside of Grey Bruce. Nevertheless, these cases are resident from Grey Bruce, and they transmitted to nobody else, including their family. This person transmitted to 2 family members and a boyfriend. Mapleview, that's long-term care before universal masking, and there was a high level of proportion of people with dementia. It's really difficult to restrain people. We don't use chemical restraint or physical restraint. Nevertheless, that was mitigated really nicely by the healthcare workers. This is a graph from the past. It's just easier not to expose privacy to anybody if people know somebody who had been a case. But this continued until this day. Most cases don't transmit to other people, and that really speaks to the fact that everybody has been doing the right thing. The public has been engaged, informed, concerned, but not afraid, and that I'll touch base on these parts. Local political commitment is one of the pillars of the response in Grey Bruce. There are 5 pillars I usually utilize every day to see how we can navigate certain aspects. MPPs, local political leaders, local community leaders, including people around the table. People emulate you and follow what you project to the public as information. The group has been very efficient and effective in the response. The media has done a bang-up job in Grey Bruce. There's only 1 story, not 2 stories. It's COVID, and how can we protect ourselves, our families, and the community? And you can see the provincial media did that in March and April. Then, it goes back to slippery slope where the media goes two sides to the story. And sometimes what really makes me shake my head is there is one driver of the emergency. It's the chief medical officer of health and the decision makers, the cabinet, making the political decision to support that scientific decision. And when you find somebody commenting on their performance when they don't really have the qualification or the picture or the information on what's going on, it's similar to somebody commenting on a brain surgeon while the surgery is going and critiquing what they're doing when they're not licensed brain surgeon. It's just inappropriate. I call it trespassing, knowledge trespassing. You would find somebody who's not specialized in public health weighing in, whether they're a physician or not. And again, going back to this result is directly related to the pillars that everybody's following the response from Grey Bruce Health Unit, whether it's the media, the local political leaders supporting the cause, the public, private companies, Bruce Power, Chapman's Ice Cream, the healthcare system definitely is a pillar. Luckily, in Grey Bruce, we utilized it only in supporting and preventing. The number of hospitalized people have been a handful, less than 10 or so. Nevertheless, they have been our insurance policy, and we know if somebody falls off the wagon, they have been very successful in bringing them back. The primary goal of managing the emergency, and it's not just contact tracing, that's one aspect of it. It is two things: achieving herd immunity, hopefully through vaccine, and that's as a humanity, we really produce the vaccine with a very short period of time with the technologies we have. And the second goal is twofold: minimizing death and disease from COVID and from measures against COVID. Most people think this is our goal in public health, to shut it down, lock it down. And it's actually not. It's a paradigm shift if you want to think about it. Our goal is to open as fast as we can, so long it is safe. I care about the mental health of people, about death related to suicide. Negative effects gonna be affecting the projected health of a person or children down the road. Domestic violence, unwanted pregnancies, those happen in pandemics. They're not new. The health unit has been working on all those as well. We actually in March, last March, we were communicating about birth control pills, because we don't want somebody to be pregnant having to go through the system if they were not planning for a baby in the middle of a pandemic. And we have been successful in addressing those issues. Social disruption or civil disobedience, we hope we don't see that. It is one of the things that are very disruptive in a pandemic. And I mentioned in the 1918, the history and case studies would show that there's a possibility. In Grey Bruce, we didn't even get close to this. Now you would hear about restaurants or businesses wanting to protest and open despite the direction. And that is dangerous in the middle of a pandemic. We need to follow the science and the advice from decision makers based on the science. Herd immunity, there are different ways to achieve it. Uncontrolled outbreak, that's a Swedish experience, didn't really do much of control, and they had 4 times death more than the 4 Scandinavian countries around them combined. And that's not the way to do it. Dynamic physical distancing, nifty idea. In practice, it's not good for the economy, not good for the control of the disease. Phased lifting the restrictions, that's what we planned early on, and that's what the ministry and the province followed, and it is, according to the science, the best way. Hammer and dance is like to lock it down for 6 months and open, and it will be gone. Obviously, it's not gone even after a year. I should mention here, if you Google any public health agency, whether it's Public Health Agency of Canada, Public Health Ontario, CDC Atlanta Center of Disease Control, you'll find that economy or income is the main determinant of health. You will find a list of social determinant of health, what makes health better or worse, and guaranteed top that list is going to be income. And that's why it's important to look through the emergency. It's not, the 6 months or the year, it is the 10 years after. In SARS, the economy in Toronto related to tourism didn't recover for 8 years. And if we decided in Grey Bruce to take the advocacy approach or whatever, it's not advocacy per se, but you'd find people advocating, let's lock it down, let's get the visitors not to come here as if, this is going to prevent disease. Well, no, they came all over the summer as visitors during a weekend, or people who come here to spend half the year. They are resident. Either or, there was no reported case of transmission from a visitor to a local or from a visitor to visitor. When we connect with other health units to track outbreaks, we can measure this. So we managed to keep the economy open, to allow people to have the summer to enjoy and prepare for a second wave. And by definition, allowed tourism in 4 or 5 years to stay active in Grey Bruce. Part of our economy depends on tourism, and we would have shot ourselves in the foot if we locked down all summer for no good reason. Obviously, balancing these two, that going back and forth, balancing these two is a science, and I can say firsthand in Grey Bruce we have managed that. Again, herd immunity is what we're aiming for. There are different roles for the health unit. The last one is the most important: communication. Put the information in the hand of the public. Each individual, I trust the community, I trust people would do the right thing as long as they have the information at hand. The majority of people have been doing the right thing, whether it's related to mask or social distancing and other. And I realize I'm not naive. People are, sometimes they get tired, they ignore the recommendation. But if you have 60% of the public doing the right thing, that's a good day. In Grey Bruce, we have over 90% doing the right thing at almost all times, which is great. It's a privilege to work with the community and the partners here. Management of cases and contacts is another complex set of protocols. And we do many other things. We lead, we collaborate, we mobilize the community. Those are not just phone call to a person to say you have COVID. There is the clinical part to walk them through the diagnosis, how they're going to protect themselves, their family, and support them. There is a legal aspect of it. How can we protect everybody else? The workplace. There is ethical. Sometimes, you have to manage certain things. A single mom with 3 kids, and isolation for her means catastrophe for that family. It can really scar them for a long time. It can affect their income. So we have been supporting people in many ways that I can start counting now, I'll finish tomorrow. We provided cell phone for people who don't have a cell phone, and that's donated by a certain communication company. We provided dog walkers for families who are isolating, and to choose a dog walker who's actually a recovered case to volunteer. So if they interact with that family is safe. And these things, you're not going to find them in protocols. It is an effort of people who are professional in what they do and problem solve. And there are technical aspects to it. We have software. It was piloted in Grey Bruce. CCM, contact and case management system, was piloted here, used provincially right now everywhere in the province. And it is a very robust software. If somebody is a case and they named a location they were in, any person down the road with that naming of that location is flagged for us, or there are certain aspects to the software to cross-examine information, not necessarily the location per se, but others. So we do have the expertise, we do have the authority. Communication is key. This is like a very simple, but usually if a person cannot say it in simple terms, they don't understand it well enough. And that's something Einstein said. A gentleman with the name of Peter Sandman, as a physician and public health specialist who built a career around communication, that anything you do in public health, you need to communicate to many partners. And this is a very short list of a longer list. If we are going to respond to a case in a school, the public needs to be aware of it, because if you don't put it out there, the parents will be freaking out, calling, is my kid exposed or not? The Board of Health, the school officials, the local political leaders. When a person calls the mayor and the mayor said, yeah, don't worry about it, public health got it, I already know exactly what it is, it's not as big as you think. That builds trust, and that trust is a cycle. Next time we call that person to say isolate or to say social distance, they will trust that. And the mayor, of course, would have more trust in our response, and will have more trust in the community. And it feeds into each other. MPPs have been doing a bang up job. I can talk about this for hours, and I should quantify it as a medical officer of health. I am a nonpartisan. My position is nonpartisan. And I've voted for many parties, different parties. I vote for policies, not politicians. And I'm talking about the functions of the position for these MPPs. Unbelievable work. And sometimes we joke about it, even in the media, that we talk to each other more than we talk to our spouses. And my wife would agree with that, definitely. She's a trooper. And I'm sure after this pandemic, she will ask me to either take a vacation 6 months or retire. And I will do that. Relevant hospital CEOs, relevant assessment center in the area to know that somebody's going to be coming for testing, or to tell people don't test right now. It's not time. Public health said, wait. Ministry, other health units, other stakeholders, and the list goes on and on. It's an art and science mainly, but there is art to it. How to keep the public in the middle, happy spot, happy in a way that they're informed, they're concerned, but they're not afraid. Outrage management, if you find the public to be here, very upset about something that's not upsetting, upset about a change in policy or mask or non-presence of immediate testing. Nobody's dying, but people are upset. Wind turbines probably is a good example. Nobody will die off of wind turbine unless it falls right on them. But people were very upset. And you would find lead in certain products. People are not aware of it. You need to actually give them enough precautionary advocacy to move them here, to be concerned, engaged, and act on it. If they're outraged for no good reason, and I'm not saying wind turbine, that they have their issues, but it's not equivalent to an outrage. We need to calm people down, give them information. Crisis communication, if there is a huge outbreak in a place, we need to communicate to that group in a way that we give them the information, but at the same time to say, like, we cannot minimize it. It is serious and you need to act on it. And that's what happened in the first wave and in the second wave at a certain point. This is a useful graph for people, even in your personal life or in your business, to utilize. It comes from Johns Hopkins. It's most credible medical school in the States and one of the best institutions in the world, public health-wise. They put this for COVID, and these are the control measures as categories: physical distancing, engineering controls. That's the shield in front of a bank teller, for example. Administrative controls, policies to ensure certain aspects are in place. Cleaning can happen at night so people are not crowded in one place with the people who are using the workplace. PPEs, mask use in public is the weakest comparing to these. And sometimes you'd find people very upset, like, how come that parent is sending their kid without a mask? Well, focus on this. You will get more bang for the buck. It's not one or the other, it's all of them. And if one didn't exist, other things will protect our kids in schools, will protect us. This is king. 1 meter or 2 meters, engineering controls, again, another one. So the mask is useful, and so the efficacy around 10%. That is to say, if Nobody wears a mask, we get 100 cases in the coming 2 months. Everybody wears a mask, we're going to get 90. So 10, but if you apply it on a population level, it is extremely effective. 10% of the cases in Ontario is a big number to prevent, knowing that the price is simple cloth on our face. And people say, why didn't you recommend it in the first wave? Why didn't you recommend it in March? Well, there are different criteria for that application, for that public health intervention. The most important two are if there is risk of transmission, community spread, and there is risk of interaction among people. So if you go back to January 2020, when we were talking about it, it will be futile if I was wearing a mask at that time. There wasn't community spread. You fast forward to April, there was community spread, but all of us were in our houses. So it will be futile again for me to sit on my couch alone wearing a mask. You recommend a mask when opening happens, May, June, July, and you can hold back until the higher risk, which is the third opening stage, where at that time we pulled the trigger on the mask, and understandably people might get tired of these measures. In Grey Bruce, most people use masks, and that's great. Sorry, I'm just finding some trouble moving slides, but here we are. This is another useful tool. We used it in March and April to prepare for the reopening stages in May, June, and July. And it says the risk of transmission is dependent on multiple variables. These are three main ones: the number of people in activity in a limited space, the length of time. If you're passing somebody on a sidewalk, even if you're 1 foot away from them for a fraction of a second, it's not that risk. 15 minutes or more face to face within 1 meter is risk. The ability to modify. You look at golf courses, they open first, and we knew they were going to open first. And when the ministry announced their plans, it was not a surprise. We actually proactively disseminated our reopening plans to every business in Grey Bruce through the counties, and we had town halls. So people were prepared. And to my delight, the ministry used the same science we used. Obviously, it's the same source to have similar plans. Golf courses opened first because small number of people in a large amount of space, and they don't have to interact close together for any period of time. It could be zero. They can talk across the field sometimes. Versus you put the other scenario on the other side of the spectrum, opened last, bars. A lot of people, limited space, talking loud over music, getting drunk. That's all these things don't help lower the guard. So people don't have to be getting drunk in bars. I shouldn't prejudge. It could be just a happy hour. And close to the end of my presentation is, sorry, I just moved my computer to see the screen I'm finding trouble seeing it. Continued emphasis on intervention. Until we have the herd immunity through vaccines, it's very difficult to go back to normal. It will be modified normality until we have that herd immunity. And the vaccine, obviously, now there are multiple vaccines. I put this slide actually together in March, in a presentation in March, or a bit earlier to the Board of Health, that this is going to be happening. The speed of producing a vaccine with the new technology is so, and it wasn't, my own prediction only. It's a science that would say this. And no global eradication. You'd hear articles that we need to eradicate it, to bring it to zero. Good luck. Eradication as a concept has different criteria of principles. The first one is the ability to biologically eradicate it, and COVID is not. That has multiple strain, it's the RNA, so there are going to be multiple variants, and we have seen that, and that's the norm for this type of viruses. We can ensure there is enough herd immunity through vaccines, and it's going to become a common cold down the road. What we witnessed in 2020 is the birth of a new common cold. It's a pandemic, but in 5 years, people will get COVID similar to common cold. It's the same family, coronaviruses. You get them and you have immunity for a year or two, then it goes away, then you get it again, and at some time you get enough of these families that you don't get it as much. So down the road, it will be back to normal. There is something common about pandemics, and it's good about pandemics. People don't think there is. All of them end, and this one will end sooner. Vaccine, there are slides here just in case people have questions about the vaccine and the rollout. I can go in more details, but in general, the plan to vaccinate based on priority is the norm and the science of it. NACI, the National Advisory Committee of Vaccines in Canada, similar to the FDA, is the agency that would set these priorities. Then each province would take replicate that list and just adjust it for local needs. Then the medical officer of health will execute that. So we don't put priorities, we execute it. And we have some leeway to change certain things based on local context. For example, EMS in Grey Bruce would give the vaccine to people down the road, and they have been frontline. So we give them a bit more priority than other healthcare workers. Firefighters and police respond to EMS calls in rural areas. It's different from urban. So both of them can qualify with the healthcare workers. Of course, long-term care and older adults are the main priority. Many MOHs, I would say all MOHs, usually we don't agree on everything when it comes to application because there are different local needs, but this one, everybody agreed. Everybody over 65 should get the vaccine. There was a pivoting to go to include the 80 plus. Again, it's not, if it's my decision, I'll go to the 65 plus, but of course, it's a provincial and system based, and it's not, I'm not saying it's not the right decision, but in Grey Bruce, we have the capacity to vaccinate fast if we have enough vaccine. And I would have gone with that number. And soon, in the imminent future, we're going to get more vaccines. My understanding, late March, early April. The issue is going to be how much vaccine we have and how can we keep up with it. And in Grey Bruce, we are prepared for that. There has been vaccination on the phases that the province put. The first phase has long-term care that was completed as a sector, resident staff and caregivers. First shot and first dose and second dose in the process. The second one, retirement homes, healthcare workers, they're almost complete. EMS complete, firefighters and police. We started that last week, and 80 plus this week there are clinics, and we have been piloting the software for. If I had this presentation last week, I wouldn't be able to say anything of this, and people would ask, how are you going to capture people? How are you going to map them out? And we used lists from healthcare providers to capture 80 plus, and people who don't have a healthcare provider, we call them orphan patients, or people who have physicians outside of Grey Bruce. We had a system to map them out through a phone 1-800 number. But at the same time, we have been piloting the provincial software that was announced a couple of days ago, and the embargo is lifted. So I can share with you that it has been a great initiative, and it's going to make all the difference. March 15th, when it's going to become available to the public, people can just go and register themselves with two IDs, similar to what we do, two identifiers, sorry. And people who don't like to use internet or cannot use internet for access will have 1-800 number and a call center to support that. All in all, nobody will be left behind. We have different systems, two main systems for vaccines. I'll finish with that. The traditional system, the pharmacy and the family health teams, healthcare providers, long-term care, the health unit supports that system, and it's going to be very active. And we actually added to it some beefing up, where we mapped out organizations that have spaces that want to volunteer the space for mass immunization. And we have a list of over 20, and it's growing. Then we mapped out the physicians and pharmacists who are willing to go out of their clinic to vaccinate in mass clinic that will provide, and there are quite few of them. So we married these two lists. So any physician in a community who would say, I want to vaccinate more, you can appreciate in a clinic or in a pharmacy, if somebody's going to be waiting 15 minutes to recover, there isn't much space for that. So we will provide that space. And we have started the list of volunteers since November, and it's still growing. And these volunteers will be matched with these locations. So this is the first traditional system. The second one is the mass immunization hub. And that is the invention that I'm very proud of. And we have had calls from different cities, Ottawa and others, that want to replicate this. As far as Australia, one of the states in Australia asked the general's team for the blueprint. Other health units have been asking, and they wanted to replicate it to vaccinate 5,000 people per day in one arena per 5 healthcare workers, staff vaccinators. So there's plenty of people who are supporting them in the task who are not clinical, and that's going to be the benefit of allowing healthcare workers to take care of patients in the system instead of spending hours and days vaccinating. So I'll stop there. Those are the references and those are the questions. And I'm sure some of the questions are going to address the points that I've not mentioned yet.
Well, thank you very much, Dr. Arra, for that. And it's my privilege and pleasure to field the questions for you. And perhaps one of the first one, you've been talking about the vaccination hubs, and we've had many complimentary comments in both in chat and in the thing about your initiative to do that. There was 2 or 3 questions were related to how did you select the geographical locations, and why, for example, the fastest growing community in Bruce, Saugeen Shores, doesn't have one?
All good questions. Every community will have a community center where we can run mass immunization clinic, not a hub. The hubs, the question is how it was selected. We selected the arenas that are closer to hospitals because these were set up as field hospitals last March and April. If the hospital system was overwhelmed, we would have more capacity close to it. And that's the reason these 3. And people might not know, but there was a 4th field hospital, the equipment for it that could be deployed in any community in Grey Bruce, a floater. That was never used, and that's great. It's like our insurance policy on our car. We don't wish to use it. So converting a field hospital to a hub is a task of a couple of weeks, and that's where we started to convert them. Nevertheless, any hub, for example, Hanover, is going to be servicing all Grey Bruce, because people who would go there will reduce the pressure on the other system, the pharmacy and the healthcare provider. And these hubs are not going to be operating for months. You can appreciate there are 20,000 people in the catchment area of Hanover. That's for the operation of that hub. And when they're vaccinated, that entire hub can be moved to Saugeen Shores or to other places. And I've been in contact with the mayor there, and he's very proactive, strong advocate for his community. The thing is, with vaccine mandate and public health mandate, it is my mandate. That's what keeps me up at night. I know, it's not a matter of advocacy, but he has been very proactive in actually identifying the need. It's worth mentioning some municipalities put vaccine plans to mirror our plan, to align with us, which is great. And Saugeen Shores and Mayor Luke was one of those mayors. So that's the reason why we started there. Nevertheless, it doesn't end there. It just starts.
Okay, thank you for that. Another common question is that we've got a lot of people interested in wanting to volunteer and help. I'm personally aware of 2 initially. One is the 2-on-1 system, and I'm a volunteer for that already, and I've enrolled, and I'm waiting to do the training next week. But you may want to talk more about that. And then the other one is the Davidson Centre in Kincardine. The Rotary Club in Kincardine have reached out to a number of people to help at that particular centre. But I think the more common one is, what opportunities are there, and how do people register to volunteer?
Our website, the Health Unit's website, it has contact information if a person is interested, and we receive this on a daily basis. We have a list that's growing by the day, and we appreciate the effort. redundancy is a virtue in emergency. So, it might be efficiency during normal days, what we aim for, to say we need 50 people, and when we get 50, that's good. But, in this emergency, it's a long lasting event. You close one door, you have two doors open. So I would welcome and I would encourage people to submit their names, and hopefully we would not call them, but if we need it, we would.
Yeah. I think we have some very social members in our group too. And one of the questions was, what are the guidelines for having non-family members in your home for a drink or for dinner or to stay overnight?
Well, we are in the green, and that's the result of the investment of everybody around the table. The goal of public health is not to shut it down. Again, as long as it could be done safely, it is acceptable. If you look at the data for cases in Grey Bruce, over 70% at all times have been acquisition in a family and friends. It's not the stranger who's coming from the big city. It's not the Mennonite and Amish community. It's not the others. It's so easy for people just to slippery slope, point the finger at somebody and say, you are the cause of all my problems. It is actually the pandemic. It's a hardship for many people. So if we stay calm, we look at that from that point of view and not focus on those issues, it will go a long way. So going back to the family, having any activity, and people would think, it's like my family, my friend, they cannot really give me the disease. It's actually us, any one of us. And it's safe to wake up in the morning and remind yourself, I am a carrier today. If I consider myself a carrier of COVID, asymptomatic carrier, and I behave based on that, I protect myself, I protect my family, I protect my friends and everybody around me. It's a very simple principle. Just wake up in the morning and say, if I am a carrier today, what would I do? You push that Tim Hortons door and you start looking for that hand sanitizer because somebody else touched that surface before you. So again, I would ask people to stay the course. Like, I know everybody's missing their family and their friends, and it's an innocent visit, but that's a visit that might transmit it to your friend who's young, then transmit it to somebody else who's old, and that person's going to pay the price.
A little bit more detailed question coming up now. The person says, I'm in my 70s and my partner's in their 60s. Will we be able to get the vaccination on the same day?
Well, right now is 80 plus. So that's a regulation. It's based on risk. When a person is 65, they have a risk of a certain number. You go to 80 plus, it's way larger. March 15th, everybody can register. And if a person is not in that category, they will not be able to register. So all these questions will be answered electronically. And when we have enough vaccines in Grey Bruce, we are ready to deploy it. It doesn't matter. I should have mentioned that when I mentioned about the hub, if you can allow me 30 seconds on it. There is a lot of work and anxiety to say who comes first, the police officer or the firefighter, and when you have 5,000 per day per arena, you can appreciate all Grey Bruce would be 10 days for one round. And of course, it's going to be longer just because the volume, the bottleneck is the arteries in a town to get that many people in. Nevertheless, if somebody's in their 70s, somebody in their 60, probably it's going to be a couple of days in between in Grey Bruce when we have that plenty of vaccine.
Okay. We've had a couple of questions regarding if they live, let's say they're a cottager and live here in this part of the world, but they may live in Guelph, for example, where do they get their vaccination?
So the allocation provincially is based on health units. Residents from Grey Bruce will receive the vaccine in Grey Bruce. There are some exceptions, like if a healthcare worker working in Grey Bruce, but they're a resident of London, their risk is our risk, right? So protecting them protects our residents. In general, people get the vaccine where their residence is.
Okay, thank you for that. The question of do the people have a choice which vaccine they receive?
There's always a choice. You can refuse the vaccine when it's given to you. My recommendation is not to reject any vaccine. Moderna and Pfizer have 95 efficacy, both of them. AstraZeneca was licensed recently, has lower efficacy, especially in older age. And the reason is the vaccine works through an immune response. So the body will mount an immune response, and the older we get, the weaker that response is. Nevertheless, any vaccine is better than nothing. And it's not the last time we're going to get the vaccine. So you can get one now, and after a year or two, you're going to get a different one. More or less, like all of them are useful and helpful.
Okay, we have a question from a school teacher here regarding sanitation, really, in the school, and he was talking about you had to sanitize all the equipment, and listening to you talking about how the spread, is that actually a worthwhile exercise?
Well, we can always add layers of protection. Nevertheless, what we have in our schools in Grey Bruce is more than sufficient. We've opened schools for over 5 months right now. Not a single outbreak of caliber. There was one outbreak of 2 cases, and it's an outbreak with identity crisis. That's what I tell my staff, because it's 2 cases and there isn't that relationship. So you can't say at an outbreak. Nevertheless, what we have in our school is sufficient, and the data speaks for it. Schools are safer than our homes. Workplaces are safer than our homes, and that's based on the 80+% of the public, 80% or more, getting the virus in their homes and through friend and family.
Okay, what is your view on extending the time difference between the first dose and the second dose? And I think that probably equates to what's happened in the UK.
Yeah, that is not unexpected. The clinical trials said 21 days for one vaccine, 28 for the second, but there were the data came from the clinical trial. When you apply it in the public and you have different people who took it at different dates, then you measure the immunity and you realize both of them have the same immunity. You can say, okay, we can go to that length. Then you would find a group of people who didn't take it for 3 months and they got the vaccine and it has the same immunity. So it's a matter of time of collecting data. And we know with measles, for example, you take 2 doses. Whether you take it in 2 months or in 2 years, it's the same efficacy. But science cannot say this is effective enough until it really is measured.
Another question is, do you think there will be a third wave? And if so, when do you anticipate it arriving?
Well, if you ask me this question in November, I would say no, because we would have been vaccinated, everybody who need to vaccinate. With the vaccine rollout being slower in Ontario than expected, and that's again multiple factors. The province, the provincial colleagues are doing everything and beyond, and I can attest to this firsthand, meeting with them twice a week or more. It's international supply. It's multiple variables that above our control, over our control, outside of our control. Sorry. So if you asked me this question a while ago, I would say we'll be ready now. Without the vaccine reaching that close to herd immunity, there is a potential for it, and usually it happens seasonally. If our audience would Google Spanish flu epidemiology curve, you would find 3 waves, and it's literally the same waves like COVID. The first one is small, the second one is 5-6 times bigger, and the third one is smaller. And that would happen around the same time in the spring. The first one happened.
Yeah, there's a question is for people who can't travel, how do they get to a vaccination point, and is there any help or assistance for them?
Yes, we have actually planned many scenarios, and that's best management in emergencies, because there are gaps in information. You don't know which one is going to pan out, and we need to be prepared for all these. We have mobile units. We have the EMS who would help us in the field. Are we going to give people the vaccine in their bedroom if they need to? But do we want to really start with that? Many people would say, yes, I want it with a massage, right? So we need to be careful on how we deploy our resources. Our goal is to provide it to as many people, especially the people who would suffer from the disease first. Then we will alter our plans to give it to everybody in their communities, and people who cannot be mobile, we will ensure that we get it.
I have a question here which I find fascinating, and hopefully you'll know the answer to this one. Do you ever see Ontario moving to a plan like BC, so that's British Columbia's rollout?
What is BC's plan, if there's an elaboration on it?
I don't know. We can ask the person who made that question. If you can put some additional information in for us, we'll try and answer that. While we're waiting for that, we've had quite a few questions regarding this thing about, well, I'm going to move up to my cottage in May. Will I still qualify for a vaccine in Grey Bruce? And I think you probably answered that by the way, from what you said before. It's where you are normally resident, I guess.
Yeah, where a person is resident. Nevertheless, if somebody's here for the whole summer, they are a resident. And when we get to May and there's abundance of vaccine, we're not going to hold back.
We've just had some elaboration on the BC thing. Apparently, if I read the response right, they are looking for a 4-month interval between the first and second dose.
Sorry, can you say that again?
They are looking to a 4-month interval between the first and second dose.
Oh, I see. My understanding, again, there will be plenty of vaccine in the imminent future. So, separating the doses. Again, the recommendation is over 21 days or 28 days, and now there's some extension through NACI's recommendation. Yeah. I'm not sure if I answered the question right, or I'm not getting the question right.
I'm sure the person will soon field as another question if that's the case. Another question about AstraZeneca. Is it recommended for those over 65?
So over 65, it would not produce the same immunity like younger people. Nevertheless, if it's the only available vaccine, I would not say no to it.
Okay. So we're looking to have really come towards the end of the questions, and it's coming round to the hour interval, which is perfect. So I'm going to pass you over to Sylvia.
So thank you so much, Dr. Arra. We so appreciate you being here and for answering the questions. And we apologize if we didn't have time to answer all your questions. Our Rotary Club here in Southampton just wanted to serve our community by opening our meeting to as many people as possible and having the opportunity to listen to your presentation. We did have 185 people register, which is great, and we're so pleased. That's about people in about 10 different communities, and somebody's actually joined us from Florida as well, so maybe they're planning to return to Great County. It's been very reassuring to hear about the work of the health unit and how it's managed the pandemic. And again, great to hear that our community is 90% compliant in abiding by the rules, if you like. So we appreciate you taking time out of your very busy schedule. I'm sure you are so busy these days. But as a recognition of you taking that time, our club would like to donate $250 in your name to the End Polio initiative. It's been one of Rotary's projects to eradicate polio for over 35 years, and because of vaccinations, Canada has been free of this disease since 1994. So I hope everybody goes out and gets their vaccination for COVID too. So once again, thank you so much, Dr. Arra, for your presentation. The information you provided is so very much appreciated, and I hope everybody else feels as reassured that we're all in good hands. I'd like to thank our techie, Brian, who's been administered this meeting for us and made it all possible. And I'd like to thank everybody who joined us, and we were going to end with a short video about our future upcoming fundraiser called Culinary Awards on Huron Shores, which is a series of online cooking classes. So, we've also are planning a St. Patrick's Day Zoom party. So check out our website. It's www.southamptonrotary.com. And I'll say good evening to everyone. Thank you once again, Dr. Arra. We so appreciate your time. So take it away, Brian. Good evening.
Hi everyone, it's Anne-Marie from Shoreline Cooking Studio, inviting you to join me on Friday, March 12th at 6:30 for part 1 of Virtual Culinary Wars. The Southampton Rotary have challenged local chefs to compete by bringing you an evening of culinary excellence. Who says you can't travel these days? We're going to take you on a culinary journey to Italy that you don't need a passport for. Learn to make Italian classics with modern twists using simple techniques. It's a trip you won't want to miss, so get your apron on and get ready to cook with us in Italy on March 12th. Ciao!